Good evening, everybody. Recenter myself here. Welcome to the June board meeting, June 25th board meeting. We're going to call open session to order. David, if you wouldn't mind reporting actions taken in closed session.
Sure, thank you, Chair McGeary. The board actually considered 5 items in closed session. Item 5.3 of the regular agenda was pulled, and that was replaced with the special, with the closed session item from the special meeting, which was a conference with real estate negotiators. So with respect to 5.1 closed session minutes, those were approved on a 5-0 vote. Item 5.2 liability claim, the claim was rejected on a 5-0 vote, and I would refer you to the agenda for the particulars related to that one. Regarding real property, which was on the special meeting, there was no reportable action. Item 5.4 from the regular meeting, conference with labor negotiator, no reportable action. And item 5.5, the medical staff credentialing, those recommended credentialing recommendations, those were approved, also on a 5-0 vote. That concludes my report.
Thank you very much. Item 9, any deletions or corrections to the posted open session agenda? None. Item 10, any audience input this evening? And again, these are for items that are not on the posted agenda. Do I need to remind you of the 3-minute rule?
Yes, and thank you. Good evening, Chair McGeary, Board of Directors, Louis Ward, Chief Operating Officer. It is no surprise to you that we have some of the most talented people in the world here at Tahoe Forest Health System. And tonight I'd like to just showcase some of the talents here at Tahoe Forest. So if I could ask Jim Frankham, our Director of Pharmacy, to come up. What you might not know about Jim is actually a climber, really enjoys waterfalls, outdoors, and he's now an aspiring artist. He's done something really neat for our health system, and I'd like to show it to you tonight, and he has something that he'd like to read.
All right, well, thank you. Thank you, everyone. I feel awkward talking to a group like this and not mention something about antibiotics or something, narcotics. So this is a piece that I made, reflects the landscape of the community here. It's made from retired climbing rope. This is the first rope that I ever climbed on when I was 14, back in the 80s, in the good old days. And so this is just kind of like a reflection of the area and reflects my love for the outdoors and for Tahoe Forest with the logo. I started to do this. This came kind of at a place of difficulty for me. I was recovering from some health issues and just kind of found myself sad because I was not able to do some of the activities that I could, and so I was staring at the rope, laughing at me for not being able to use it, and so I decided to cut it up and turn it into art, and that'll teach it. So anyway, so this is kind of like I feel like I got a second chance because of this hospital, and these are second chance for my ropes. So there it is. That's less than 3 minutes, right?
Thank you very much, Jim, and no doubt this will find a home somewhere in the health system. We haven't yet decided exactly where. We'd love your input on that. But it, of course, shows our great logo here in the middle of the lake, and so it's going to find a nice home and be up for a long time. So thank you again, Jim.
Thank you.
Jim, thank you so much. Anyone want to try and top that? Okay, no more audience input. I thought so. Do we have any input from employee associations? Looks like we don't. Item 12, President and CEO monthly highlights. Anna, good evening.
Good evening, Chair, members of the board, community and staff that are joining me. I'm really excited to provide some highlights. Tonight's actually a pretty dense night filled with a lot of content. So I'm going to a little bit speed through these, but I wanted to start sort of at the beginning to talk about some new faces that we have here. I think you've had the chance, but I want to make sure the public knows that we have two interns here. I'm going to go from the bottom up. Sarah Hardin, who's from USC, and Sarah Molina, and she's from UC Davis, and they're both spending their summer with us to work on different aspects of health, community health. Sarah Hardin is actually grew up or is from South Lake Tahoe, and Sarah Molina, and by the way, they sit next to Sarah Jackson. So they're all in the admin building, and like they're literally, within 5 feet of each other. So we go Sarah, and a bunch of people answer. But Sarah Molina is from Richmond, California, and we're just really delighted that we have them here this summer. They'll come up and provide some comments if they'd like, but they'll also come back at the end and kind of tell you how they spent their summer. We're trying to keep them very busy, but we're really happy. This is our second cohort from Health Career Connections. So again, thank you to Louie for hosting them. Where's Louie? Oh, there he is. So really, really grateful. And I think one of the things I want to say about the interns is sometimes that they feel like they're coming here to get an experience with us, but they also have a big impact on all of us. So thank you so much, Sarah and Sarah, for spending your summer with us. And if you want to, at the end, you can make some brief comments. I also want to say she wasn't able to join us tonight, but Ashley Davis has been appointed as Director of Clinical Nursing Services for the outpatient, for the ambulatory clinics. So she has had a long history with us. She served as Patient Safety Officer, Nursing Leadership, Patient Safety Quality Improvement, and now she's going to be over clinic operations and really kind of bring all of that plethora of experience in, and she'll be reporting to Dylan. And Dylan, thank you for finding Ashley and getting her to agree to come out to the clinics. And then finally, I wanted to say that joining us tonight is our incoming, and actually already here, but will be physically here starting August 4th. Okay, everybody's August 4th, so don't fill up her inbox yet, is our new Chief Human Resources Officer, Lisa Faust. And Lisa is, has a deep amount of experience. We went through a national search, and really I want to just recognize our HR department, but also they worked with a external recruitment firm, and really had amazing candidates, and Lisa rose sort of up through that process. Her most recent, since she has many years, I've been told never to say how many years, but she has many years in human resource background. Her most recent was at John Muir Health for several years. She also worked in Southern California, and she actually started her career in foundation work and fundraising. So she actually has decades of experience there too, and really at one point ran foundation and HR in a large system in Southern California. So I actually asked Lisa, and she did say she would make a couple of comments, because I feel like it's really difficult to do service to the rich background that she has. She was actually working within, 5 miles of where I came from, and our paths never crossed. But I'm just so delighted that we sort of our paths crossed here at Tahoe Forest. So with that, I'll just sort of hand over to Lisa if you're willing to. You can go up to the podium if you'd like. Yeah.
Here, and I am very excited to be here as well. It sort of was a bit of a happy accident, because I was already leaving John Muir Health. I'd been there for 13 years. Quite frankly, I'm retiring from there on July 24, which is why I'm not starting here until early August. But I've been vacationing in the Tahoe area for decades, and drove past your beautiful facilities on my way to Truckee Thursday, and I know that. I was surprised that your board meets on Truckee Thursdays. But I would, look up to my right as we're driving, trying to find a parking space, and I thought, what an awesome place to work. I wonder what it would be like to work there. And then as I was leaving John Muir Health, we were relocating to Southwest Reno anyway. My son lives in Reno, my daughter lives in Auburn, and my husband has been hoping to relocate this way for many, many years. He's been a very patient man. So when I got the call about this job, I thought, you bet, I'm interested. Let me please give you my resume. So I am passionate about leader development. I'm passionate about employee engagement. I think those are two things that are in my wheelhouse, and I have so far, just in the 2 days of soft start that I've had yesterday and today, this is an incredible organization, and people have been here a long time. But you also have some wonderful new ideas coming into the health system as well. So I look forward to the challenge and to working with a wonderful team and senior leaders and the board. So thank you for your welcome.
So we are so happy to have Lisa here. Louis particularly. It's just like, can you start now? So anyway, we're just, and thank you, Lisa, for being here tonight. If we could top that, I just wanted to give a couple of, just some highlights around some work that we've been doing. This last month, we've increased by 73%, 2 years in a row, our wellness visits. So again, I just want to acknowledge Lauren and her team and all the people who are working there. I also want to recognize the nurses who last month was Nurse Week, and the nurses actually donated. This is the second year in a row they've done that. They donated their own money to local nonprofits, and this time they donated to the Scotty Lapp Foundation. Jan, are you in here? Yeah. Oh, do you want to say some words about that? So I'll let actually Jan tell the 4 organizations that they donated to very quickly.
Hi. Yeah, so we donated to Scotty Lapp Foundation, which some of you may already have known about that foundation. It was about a young man, Scotty, who I believe was killed at, I'm not sure, but I think he was he was on the ski team at the local ski areas. And so the family has started a foundation, and they're looking to also help the underprivileged with skiing, but also doing a skateboard park in the Tahoe City area. So that's what they've been raising funds for. Our other foundation that we gave to is Tahoe Community Services, which we really wanted that to go for people that are in need of type of services, like the nurses really wanted to go for people who are in need of food or gas, or even for any type of issues that they're having with their family units. And because of our care coordination team, they work with a lot of these individuals, so they really wanted to make sure that the funds went there. One of our other sets of donations went to our own care coordination group, and that was so that we could provide gas cards for some of these people coming from Quincy, from Portola, and so that they could be able to get to their appointments in this area. And then the last donation went to the Humane Society. Like everybody here, our nurses are very passionate about their pets, and they wanted that to go in the honor of Greg Charter. So that was the 4th donation. So thank you.
Thank you, Jan, and thank you so much to the nurses. And then I just wanted to, one other highlight around community in action is I just wanted to say that I want to acknowledge Incline Village Community Hospital. This month, in May of 2026, they had record volume of infusion visits, 128. So I just wanted to say that that's been growing, and that's a really big deal in a very small community. So I just wanted to acknowledge the Incline. I wanted to just make a comment. I mean, I know this looks like we're having a party, and we are having a party here in Truckee for America's 250th Independence Day. I wanted to say a couple of things about this. Not only are we the presenting sponsor, and we will have some VIPs downtown, I think, in kind of VIP seating, board members. Yeah, might be one or two, so go down there if you're there. But I also wanted to say that there's a couple other things. We will be at we will have a first aid station downtown, and the other really important thing, and there will be more information about this on our website, but I also wanted to remind the community that Donner Pass closes from 9 a.m. to 12:30. That is the main entrance into the hospital. So the way to get to Tahoe Forest, and this again will be present on our website, as well as law enforcement will be aware of that, but is to come via 89. If you were to find yourself coming down the other way, you will get escorted through. I do want to say that, so you don't need to go down the hill if you need care, but you will need to be escorted, and our law enforcement partners are very ready to do that. So again, though the road is closed, you don't have to stay away. If you need care, we're here, and we have actually a whole process to escort you into the hospital. So I just want to make sure people know that, and we will also be down with first aid down in sort of the crowd, which we predict will be very, very large crowd this year. So we will also be sending positive energy towards our urgent care and emergency department that weekend, because we expect a very high volume of visitors that weekend. So I want to thank all the people who, in lieu of celebrating, will be supporting the community in service to our community, which is really important when you are a small community like our North Lake Tahoe region, and we are hosting so many people. To have solid health care available is really critical, so I just want to acknowledge our staff for that. I also want to talk a little bit about, just give you a quick update on the rural health transformation dollars. We did, in fact, submit for, I actually want to pull Louis up to talk about this, actually. Louis, because we did actually get one grant and we did not get one grant. I think it's worth explaining why, and I just will say on the California thing, we still are awaiting the application for that. So I kind of want to say, Louis has been working really hard on this, and you can't do any more than, but it's very bureaucratic, I would say.
Well, thank you, Anna. Yeah, Louis and team for sure. So starting in Nevada, we did actually have 2 grants that have been applied for. The first one was called a Flex Grant, and again, this is from the Rural Hospital Transformation Fund. It was $50 billion that was divided out amongst the 50 states. However, only the first $25 billion was essentially set up where it would be kind of equitably distributed throughout the states. The remaining $25 billion has to do with how people succeed, what states actually put the money to good use. So right now we're working with the first $25 billion. In any case, the Flex program allowed for construction projects. We did submit, but our application was not actually approved. There was higher needs in the state of Nevada. So it was 103 applicants, 180 some odd million dollars of projects, and they could only actually approve 35 applicants. So that one we've moved past. It was disappointing, but we've moved past. With regards to the second grant, it was a workforce grant, and we put together a really strong application. We were awarded $1.5 million, and that is for bringing in primary care particularly, so primary care physicians. So we're really looking forward to deploying that grant as those funds come in. In California, not a ton of news there. The application opens up apparently on the 1st of July. We do have some great ideas. We're working with a number of people at the moment, but we will see, because California has been pretty slow in this process, but once we get the application, we will absolutely put forth a great application, and I hope to be successful in that as well.
Thank you so much, Louis. One sort of, and correct me if I'm wrong, Louis, but one sort of caveat I want the board to just keep in mind on this workforce grant is that this $1.5 million is for Nevada. So
Yes.
one of the things that we intend to do is do a sister submission, if you will, or a twin submission for California so that we could sort of match it. But those are restricted dollars to Nevada. So I think it's important for us to kind of make that process clear to staff, because we may find ourselves in a position where we don't have a coupling on the California side, though we're really working hard to make sure that we don't find ourselves in that situation. But I do want to just say that there is some restrictions around these dollars, and as well as where you can spend them, when you have to spend them by. So we'll keep the board posted on all of that. But I want to just recognize, Lou, because this is like, they're constantly, the goalpost is being moved all the time. And there's lots of players involved in this. And really, there isn't actually a lot of rural hospitals, but there's a lot of people who identified that they should have a role in the rural health transformation dollars. So Louis remained at every table. It's like, if there's a secret meeting, he's there, because there's all these meetings popping up everywhere, but it's kept him on the road a lot. So I want to recognize Louis for that.
Well, thank you. No corrections needed. Absolutely
Great.
Correct. So thank you very much.
Thank you. Just a couple other things I wanted to tell the board, just again, this is really for line of sight. Lots and lots of work we've been talking to you about, AI. There's a lot of investment happening this year through our project management, the projects that we pick through the project management office process. And we do have an AI governance committee, leadership team sort of has established. They're actually working, Dr. Gladman, Farhad Islam, and Kyle Cattell are really working with external expertise from ECG to kind of look at well-established governance models from around the country. So that work is moving along. And again, I just kind of reassuring you, they're looking at best practices. They're taking this through a due diligence, and really making sure that we can fully get the value out of AI, and we also can sort of mitigate for any, I think, of the plethora of concerns I think there are around AI, but I just want to make sure that we just sort of have our A team on that, and that's moving along. And you're going to hear more from Farhad a little bit later tonight. I also wanted to just say that we finally had ACHC visited us. We had our ACHC survey at both Tahoe Forest as well as Incline. We actually, I will just say, we'll send it to you, but we literally recorded the board, the surveyor, because we had an open Zoom line, but she literally said that she had been surveying hospitals, both large metro acute care hospitals as well as critical access hospitals, and stressed that this was by far the best one she had ever been to. And she said she had been surveying for over 30 years. I literally said, as it was coming out of her mouth, can we reuse this? But we could, the audio, we have not been able to refine it really well, but we do have the audio for you. I mean, she wasn't even done saying it. I was like, can I use that? And then the next day, actually, they went to Incline, and then they actually identified Incline as a valedictorian of critical access hospitals. I'd like to say in Nevada, we have the two best that she's ever seen, but they were extraordinarily complimentary. We did have some minor, areas of improvement. Those plans of correction are already on the way. Is Janet in here? I just want to acknowledge Janet and the entire survey prep team. I mean, they created binders upon binders with every piece of the process outlined, every policy that a surveyor might even want, and they actually asked if they could actually copy the process and share it So I would not be surprised if we see Janet and team on some national stage talking about the prep, because they said they had never seen preparation of this level. And so I just wanted to acknowledge that. The other thing I want to say about this is they spoke over and over again about the care that they witnessed that was happening. And so I just want to acknowledge the staff and the work the staff do every day. And I think one of the most poignant things that the surveyor said was, if I needed care, I would want my family to get care here, which is a really powerful testament to what she witnessed with the staff. She said, "This is the first place I've gone to," like she said, usually, and you know, I'm a nurse by background, so I get it. When surveyors come, staff kind of thin out, you know, and she said, actually, staff were like, "Did you want to, can you come and see this?" And they were really proud to show their work. So it was, we were commenting as the executive team as we were walking over for the exit interview, like none of us were stressed at all. We were kind of looking forward to it. And we just knew it was going to be a really good report out because, again, we kind of had seen, you know, I do want to say, like, Barb was here too. Barbara was here, like, manning kind of the command center, if you will. It was just a very solid process. And I just really can't thank all of the managers, the directors, staff, you know, for all of their work that they did. And it really, I think, I wish you could have, and we did actually get the recording. We'll work on the audio, so because I wish you could hear it. It was really, you can't make those things up. And I'm not doing justice to it. Finally, I just want to say about tonight. I just want a little bit of about tonight. I kind of gave you the highlights, but other things that have been going on this month is that we've really been working hard on, thank you to the board for approving our strategy last month, and this month we're bringing you back the measurement component of that strategy. This will be really a governance level, and we'll talk a little bit more about that when we get to that agenda item. But also we have in here, in tonight's, in your packet, it will be the governance work stream and the governance plan around strengthening governance. You recall that when Alvarez and Marcel came in and kind of did the assessment of us, they kind of said, you've got 3 really big areas you need to work on, you know, access, leadership discipline, and strengthening governance. So you're going to keep seeing that come back to you. And so again, even though you're going to hear about these agenda items tonight, there's been a small army of people working on this. So again, I just wanted to say that the work continues, and this will actually be a constant work in progress. So I just want to thank the board for your support of this work. It's a little bit different than it's been in the past. I want to thank the staff for all the work they've done on it, and I look forward to us covering those items tonight in the discussion that follows. And that concludes my formal remarks tonight. I'm happy to answer any questions, or we can just move right on. Yeah, thank you.
Item 13, Medical Staff Executive Committee Consent Agenda. Dr. Cope.
So I'm here to present the consent agenda this evening, and I'd first like to request that we remove the standardized procedure and protocol for physician assistants and nurse practitioners, MSCP 10. It was not quite ready for presentation, and it will come back to you in a month or two.
Thank you.
All right. And then to discuss privileges with changes, the emergency room or emergency medicine privileges put an addition for required stroke hours, including NIHSS training. Now that we are a stroke center, that needed to be added to the privileging. And that's the only change with that policy. Next is policies with changes as opposed to privileges, and there are a long list of care coordination policies and DWFC policies and CPAP and BiPAP policies that are all, without any meaningful changes, just risk statement type changes. And then there's the standardized procedure for pre-op testing that does have some significant changes, but none of which are substantially changing policies, but rather reinforcing policies or clarifying policies. But they're much more detailed if you look at that policy. A lot of changes, but all just to clean it up and clarify. All right. And that is the credentialing, the consent report today. Any questions?
Wonderful. Thank you very much. Any questions, comments?
Thank you for the questions that came in advance, by the way. Always appreciate it.
All right, thank you. Comments from audience? All right, then we'd be looking for a motion to approve the consent agenda for the Medical Executive Committee.
I would move to approve the NBC consent agenda as presented.
I second.
David, do we have to note the item that was pulled in the motion? Okay.
13.1.6.
Maybe you want to just make the motion again with the, there was an item that was pulled.
Yes, I would make that.
Okay. Then a second?
I second.
Motion and a second, all in favor?
Aye.
Opposed? Approved unanimously. Thank you.
Thank you.
Item 14, consent calendar. Again, these are items expected to be routine and non-controversial, but items can be pulled for discussion if need be. Do we have any items on the consent calendar that would like to be pulled? It's a pretty small list this time. All right. We'd be looking for a motion to approve those then. Or to approve the consent calendar.
Public comment, Chairman Gary.
Public comment? Any public comment? All right. Now we'd be looking for a motion.
I'll move approval of the consent calendar.
I'll second it.
Motion and a second. All in favor?
Aye.
Opposed? All right, consent calendar approved unanimously, thank you. Items 15, items for board action. Item 15.1, True North 2030 Measurement Strategy. And I have a long list of people here. Presenting Andy, you going to kick us off?
Yeah, I'm going to kick you off, and then we have a bunch of people, but we're going to do a seamless transition. So again, I want to thank the board for having us, giving us this last month, giving us the direction to accept the strategy, and then giving us some time to kind of bring you back a measurement strategy. I will say too that you have in your packet, you have a written write-up on the measurement, and then you have the PowerPoint slides. So I just want to make sure that you feel comfortable with those materials. I wanted to again take us back to our Tahoe Forest True North aims. These should feel very, very familiar. Health Within Reach, which is really about access, choice, cost, and convenience. Community guided, this is really around how do we sustain the world-class care that we provide and ensure that it's shaped by the community and with the community. And then the transformation piece is really it's not just the internal work, but it does have a preponderance of internal work. It's around being accountable, making sure that we're aligned, supporting stronger governance, and then also thinking about some of those, I think, transformational kind of strategies, which is that is really where it overlaps with the community guided and being informed by the community. But you'll see that take shape over the year, but even within the measurement strategy. So we'll come back to that. But hopefully this feels really familiar to you. I also just kind of added in for good measure and is the reminder from our board retreat, kind of where we are right now. This is that model that Mark Finucane introduced to us, kind of showing where the work occurs and where we kind of are in the organization, and showing that the governance is sort of either you could say everything's nested in governance or it's overseeing everything. One or the other depends on whether you're a splitter or a clumper. I like to clump things together, but some people like to split, which is why I never try to do those multi-vote things with the yellow stickies with the splitters, because I'm a clumper. But so, the reason that I put this up here is to remind the board that there's multiple levels of measurement. And so there's, measurement that's really happening up at the board level, which is 50,000 foot where you're, positioned and you're getting the information to do good governance. And then there's measurement that goes all the way down to the ground, which is really what those frontline teams are doing. And they're really, if you've gone to one of the huddles, you saw that. They talk every day about like volumes and maybe utilization or whether the, compliance with the checklist. Those won't be the measures that we're bringing to the board unless there's a reason that something's derailing and we want to do what kind of take you through a root cause. But we're really going to be talking to you at the governance level, which I think is, again, a little bit different than maybe in the past, where I think we've moved from a variety of levels. And I would say the majority of our measurement we've talked with the board about has been operational level, which is really not governance level measurement. So if this feels a little conceptual, that's kind of on purpose. But one of the things I would just say is that you're going to hear that we're going to have all kinds of options, including office hours, to take people farther if they want to. But we really want to make sure that we're at the governance level, we're really providing you with governance level information, and also on the public level, that the public is able to follow along. So we're really going to be pushed, and I would just strongly encourage you too. We're going to try not to use technical speak. We really want the board and the public, your constituents, who, we're all accountable to be able to follow along with what we're doing. But we also want to make sure you have enough line of sight to have reassurance that there's a lot of measurement. In fact, Forhod's going to talk a little bit about this. Hundreds of measures and reports, thousands of measurements and hundreds of reports that are the governance measurement strategy is nested in. So I just wanted to remind you again, what we're really going to talk about is the governance measurement strategy, which is, and one of the things I also want to say is what it is not is the operational measurement strategy, which is also happening, but not something we're really going to be bringing to the board on a regular basis unless something is in fact derailing to a point where we feel there needs to be a policy decision or alert you that's something. And again, that is sort of the work the executive team is doing on your behalf and on behalf of our community to make sure that you're alerted for those. So just a reminder. I just wanted to also remind kind of what drives our measurement strategy and really what are the different reasons why we picked the measures we picked. Because there's lots and lots, thousands of measures that we're measuring today and have been. But you're going to see some new kinds of measures because we really wanted to be responsive to the 5,000 voices and the voices of our community. We also wanted to make sure the Tahoe Forest team here at Tahoe Forest had input into what really matters to them. We obviously, won't be kind of doing our measurement strategy won't take the place of the performance and regulatory measures that we have to measure. We also are going to be using measures at the operational level to really do trends and risk identification. So again, this is really to give you kind of a view into what's going to be happening underneath the governance, but it's all of these things are happening at once. And again, we will try to put together, I think, processes for those. And we know that it depends on what it is. And even that there may be individual board members that are like, I need to know more about this thing. We will put together structures that allow for that. I think, again, like office hours, we already have like predictions on who will be regulars, but just kidding. I'm kidding, not entirely kidding, but I am kind of. But we know that it's not just our board. We know there are members of the community. They're at home and they've kind of got their we've got some kind of people who are interested in epidemiology and different performance things, and we want to make sure that there's some space for them to feel like they can participate as well. So again, I'm not going to read all this to you. This is really to reassure you that this is really happening, and the measurement strategy is based on what we heard very specifically, particularly the new measures from those 6,500 touch points that we got from the community. And not just regulatory and safety things, though those are happening, and they will continue to happen. But we really were we think we heard a call from the community say, we'd like you to do more, and we'd like you to look at this in a little bit different way. With that, I'm gonna actually call up Farhad, who is, as you know, our Director of Business Intelligence. He's going to talk a little bit about, you're going to see a little rotating chairs because people are getting ready, because this is going to be all of us, because everybody here built this. I mean, every person in the, on this leadership team, as well as many, many frontline staff, really had say-so and weighed in on this. But Farhad's going to talk a little bit about measurement in general, just so we can do a little primer here.
Thank you, Anna. Thank you, Board. Farhad Islam, Director of Business Intelligence. Those of you who know me, you know that I usually talk technical terms all the time because I deal with data. But here today, I'm talking about some of the theories about measurement science. So I'm talking about standard metrics and noble metrics. So what is standard metrics? Standard metrics rely on established and universally accepted baseline to measure performance or outcomes. And on the other hand, noble metrics measures custom tailored an experimental indicator that is designed to capture unique and specified variable that is traditional data usually overlooks. So to provide you an example of what a standard metrics is and a noble metric is, I was trying to go to the lake or the mountains that we live in. And one of the examples that I can give you is, we have a lot of snowfall in the area. How do you know we have a lot of snow or a little less snow? We measure how many inches of snow we have in the community or on the hills. So that is a standard measure of unit for measuring snow in the community. That is the same way they measure it in some other areas where there is snowfalls. However, on the noble metric side, let's say I want to spend a day on the lake, and I want to spend a day. I want to measure the quality of the snowfall that live in the area, and let's say I come up with a metric called powder index. What is a powder index? It could be the noble metric that might measure how many inches of fresh, untouched snow powder actually reached the Tahoe forest floor without blocked by the canopy. So this is something important for the ski quality. It is something important for the quality of the moisture of the soil.
Thank you.
All right? So this would be a noble metric.
Yeah.
So that's the difference between standard. This is a metric probably not measured by someone in other areas, but if you want to quantify or get the quality of the ski here or the quality of the soil or the moisture in this community, then these are the metrics that you want to follow. And each of those metrics, standard metrics, has three different types of metrics. We have process metrics, we have outcome metrics, and we have balancing metric. And I have a couple of examples that I can share with you to properly explain what this process, outcome, or balancing metric is. One of the example is, let's say I want to spend a day on the lake. I have a boat, I want to go to Emerald Bay. My destination is Emerald Bay. If I can get to the Emerald Bay, that's my outcome metric. But my process metric would be, do I have enough gas on the boat? Do you have the navigation set up to get there? Do I have I checked the weather? Is it going to be nice weather to get there? So those would be the process metrics that we track to make sure that we are going to reach to the destination. On the balancing metric would be like, I have two sons. I have two young sons, one 4 years old and 1 year old. I have to make sure that they have enough sleep before we go there. So they're not cranky, making sure that we have a good day.
Yeah.
So these are some of the examples of process metrics, outcome metrics versus the balancing metric. On the noble metric side, as I said, the example that I provided to you, powder index, it's something that's typically not tracked. So you have to go through developing the metric. What is the definition of that metric is? We have to figure out a way how to track that, how to measure those. We have to once we have a reporting stability, then we have to establish a baseline. If we measure the index from 0 to 100, is 30 a good score or 90 a good score? We don't know. Some people would like 50, some people would like 90. We have to figure out a way to measure them and track them on a regular basis for a period of time to understand and provide a baseline, and then we can set a target as to what is a good index. So with that said, the next slide that we have, it shows you a framework. We actually got this framework influenced by a process improvement cycle, which is called PDSA, Plan, Do, Study, and Act. So it shows visually how True North started, or we presented the True North to the board last month, and we have identified what our objectives are and looked into what are the standard and noble metrics could be. And then if we have a standard metric to track, then we can track the standard metric for each of those aims area that Anna talked about just a minute ago. And if we don't, then we have to create some noble metric, and we have to start tracking them. We have to develop a way to report them, or starting to track and report and develop a baseline through this process of plan, do, study, and act. And once we have a certain period of time of tracking, then we can set some target as to this is a good benchmark or this is a bad benchmark. And then we can talk about what a great target can be. With that said, enough talking about theories. I want to give the stage to Dylan to talk about reality and what are the metrics that goes into each of those aims.
Just come on up, Crystal. Just go up.
Musical chairs.
Better way.
Do you mind moving it forward? I'm going to say a powder index is definitely novel. Yeah.
You're most
Oh, that's right. I'm in charge. So within our Health Within Reach goals to strengthen access and affordability within our community, we have three critical. I'm going to talk through the first two. So last month we saw there's some very critical investments going in specifically to primary care to open more doors to our community, more access points. And our standard metric we want to track for this fiscal cycle is adding 800 visits per month. So our current monthly average in primary care is about 3,200 visits per month. And obviously we're going to realize all those, or the goal is to realize all those investments and then boost that to 4,000 average visits per month by the end of the year. In addition to that, we're setting a target for a 30-day third next available. So third next available we've had as a target for the last couple years, and we haven't materially achieved all those targets. We have developed with Forhad and his team very enhanced models to look at, and I just want to set a target. So actually, the additional capacity with primary care is actually only going to move our third next available appointment halfway towards this goal. So within this third next available, we're achieving half by volume. We need the other half by intervention, which we are planning out, and really redesigning the touch point and how the community can access the specific services. So the 30-day third next available appointment will be considered for a combination of primary care, women's health, and pediatrics. I'll pass to Crystal.
So of course, I get to talk about the first novel metric, but I wanted to build upon Forhad's description. This is nothing new, especially in healthcare. A lot of the programs that are developed at the governmental level, they go through a period of novel metrics and just reporting only so they can learn and gather data about programs. Programs such as Prime and QIP were all built upon starting with novel metrics and reporting only. So it's pretty common. This isn't new in the industry. And so the area we're going to have a novel metric is really going to be in the financial assistance category of the True North. And to remind you, this is where we discussed lowering our over 70% of our lab tests by 25% for our pricing, hopefully making it more affordable for our community to use, as well as enhancing our financial assistance program, making it more accessible for our community to know it's there, how to utilize it, it's there for use, how we can support them to get the care they need when they're concerned about the cost of health care. Both of these areas don't really have a standard benchmark to go against. So we're going to start from ground zero on this. So for the lab test utilization, we're going to be looking at what our utilization is, and is it changing based upon the dynamic of lowering our pricing. So this will be reporting only as we watch to see what happens. Same with total financial assistance. As we work on that programming, our messaging, how we interface with our community, how we're at the front line with our patients, informing this of this, how we utilize our providers to help them have conversations with our patients, we're going to have to watch and see how that impacts our financial assistance. And so again, we'll be utilizing basically a reporting only novel metric as we kick off that program. So those are the two we plan to do in this category. I think we're going to move on to community guided, and we're going to play musical chairs again.
Good evening. You've heard me talk a lot about 5,000 Voices, and as we promised in the strategic planning process, this is not a one and done. Our interest in engaging our community is not a one and done thing. So now we're at the point where we have to figure out how we actually operationalize that continued ongoing participation of our community. And so we will be working to really figure out a plan in terms of how we take the resources that we have available to us and reach out into the community, and most importantly, how what we hear from the community comes back and influences the work. Because I think we've done for a lot of years a good job of being out in the community, but how does it come back, and how do we use what we learned? We did a good job of that in 5,000 Voices. Now we don't want to let that go. And so that is definitely a novel metric. We got to figure out what we do, what we know, and how we can make it useful to us. You all know that we have a PFAC, a Patient Family Advisory Council, that meets on a regular basis, has some very involved members who are very interested in really being an active part of this organization. So I met with them on Tuesday night and talked with them about their role, their potential role in this in terms of stepping up their voice in the community, but from the patient and the family perspective. So we will go through a process with them of doing an assessment and then putting together a very specific action plan on how we can really raise their voice and make sure that they're influencing the decisions that are made in this organization. There are sort of two pieces to this, right? There's the new piece, the 5,000 Voices, and the new work that we bring in, but we also want to show a dedication to honoring and respecting the work that's already going on, and we feel like the PFAC is a really good example. It won't be the only one, but it's a good example of something we have already in existence that we can take better advantage of as decision makers and leaders in this organization. So the next slide. We wanted with our novel metrics to give you some ability to sort of track our progress. We didn't want to sort of come to you tonight and say, this is what we're going to do, and then come back next June and say we did or we didn't do it. We want to be accountable to you in a way that says, here's the progress we're going to make. So we put some sort of milestones on a timeline here. 5,000 Voices, we'll go through sort of a lean process there where we do a state mapping event where we need to sort of determine what are we currently doing and what's happening with what we're currently doing. I will confess that even in our attempt to sort of figure out what a standard metric could be around this, we sort of determined that we don't even know everything that we do in terms of community engagement and community outreach. And so we need to start there and figure out what we're doing. And then the second mapping event will be, what do we do with that and how do we make that really useful to us? And then you can see with the PFAC, we'll do it. There's an assessment tool that's been put together by a national organization that advises PFAC councils, and so we'll use that tool. We'll sort of tweak it to our own use. I will say we had a copy of it when we talked to PFAC the other night, and they literally wanted to start on the spot. I'll answer these questions, and so they're very excited, and I really want to appreciate their willingness to do that. And then in the end, by January, we'll start to really implement the plan that they come up with. And they will, I want to say, they will really drive this. Their destiny is in their own hands. We will give them tools and we will give them guidance, but we really want them to be the drivers of this. So a little bit of ability for you to kind of follow along on how we make progress in community guided.
All right. Let's see here. I get to talk about the most important component of our strategic plan, I think, and how we're going to measure it, the transformation aspect. So
That was something that we heard very loudly from the 5,000 voices, that the community, our employees, all of us want to make sure that Tahoe Forest continues to evolve with our community partners and accounts for the massive amount of change that's going on, and we become just more adept as we go. So these measures are also all novel measures, and so we'll just go through each one. So the Transformation Summit, I think you guys are well aware of at this point. Hopefully it's on your calendar, September 25th. We will be having a Transformation Summit. It is called Beyond Possible, and we are working with community members to develop the content, the planning around this, and also the follow-ups that will come out of this. So it won't just be, a conference that happened and then it's done. There will be actions that continue to take place as a result of this forum that we put together. So that's a reporting only. The next one is in the category of board engagement. And we've heard before, and Anna made some comments already about supporting strong governance and developing and implementing a board education plan. We'll see a timeline on the next slide on some of that. And then also establishing a community advisory structure, and the details of that are to be developed. But that will be a novel metric as well. And then the final component of this is to build collaboration through partnerships. And the first part of that is a medical staff advisory committee. We had talked about a physician advisory committee, but we do want to make sure that we're accounting for the entire medical staff in that collaborative. And we'll be working through the design and we'll look at the timeline on that as well. And then we'll also be doing 3 engagement sessions that will look like town halls, essentially, for our own internal team members to make sure that we hear their voices loudly and make sure we leverage their wisdom. Okay. It's a little small, but you can see that we've got essentially, as Kim was talking about, we want to make sure it's not just a whole year passes by and then it's like, oh yeah, we did all those things. There is, a timeline so we can be held more accountable to that. So the top is board education. You'll see that one component of that is the Governance Institute Conference, which is in Colorado, that I think you're all going to be attending. For the Transformation Summit, really just one item on there, the summit itself. Obviously, there's a lot of work that's happening to get that thing off the ground and to make sure it meets our needs. But that summit on September 25th will be the big component of that. And then the lowest row there is organizational partnerships. So the town halls are built into that timeline. And then we also have some key milestones for the medical staff advisory committee baked into that as well. So that's what I had on transformation. I'll turn it over to Louis.
All right, I get to follow Dr. Evans' most important part of the strategic plan with the balancing metrics. So when we're thinking of novel metrics, and you've heard a number of them tonight, we really need to ensure that we don't address these novel metrics and have unintended consequences. So that's why we use balancing metrics. And I actually had an analogy of a balloon, but Forhad inspired me with his snow, so I'm going to try to. I'm going to try. So say you have a ski lift, right? And that ski lift obviously picks people up at the bottom and drops people off at the top. And maybe the folks down at the bottom are saying, well, we should speed this ski lift up so that I can get on it quicker. Well, that might sound great for everybody and maybe the novel metric, but the folks at the top that are trying to get off now, they end up getting spilled down the ski lift into the onto the snow because ultimately what happened down here resulted in an unintended but not a great consequence at the top of the ski lift. So if that was good, thumbs up. If no, all right.
Can you give us a water ski or something? No. We don't want to just do winter.
So speed of lift is balanced by carnage at the top.
Yes.
Gotcha.
We're not trying to drive business.
Yeah.
Plus and a minus, yes. I've seen it.
I'm sure you have. But bringing it a little closer to home in terms of the healthcare setting, so satisfaction surveys is something that we pride ourselves on. We have historically had satisfaction surveys with patients that really put us in rarefied air. So we need to make sure that that is at the core of everything we do, including with employees and physician alignment. And just thinking about it, you heard earlier, we're going to seek to move from 3,200 patient visits per month to 4,000. And, a draconian effort there might be something like, okay, every physician needs to see 10 more patients. Well, I think what we would see pretty quickly is our physician alignment scores may go down. Our patient satisfaction scores may in fact go down because patients will feel like, I don't have as much time with my provider. Yeah. So that's essentially what we intend to do with these balancing metrics. And of course, we're going to be looking at operational surveillance. There's many measurements throughout an operational surveillance, but particularly looking at operating margin, quality and safety, and workforce. We really remain as one of the best places to work. So everything we do here, whether it's a standard measurement or a novel metric, will really be seen in terms of how we're addressing the number of different metrics that you see here tonight, which we will keep them right at the center of everything we do because we perform really, really well in these areas, and we will continue to as we move forward with this strategy. Mm-hmm. And I'll invite back up Farhad.
Thank you, Louis. That was a great analogy of going back into the powder index. We can bring powder index to we're bringing it to our health system, and how can we get an index for us, our measurement strategy. So we have these three different aims. So we will have index score for health within reach. We'll have a community guided index, and there will be a transformation index for each of those focus area. And this is a dashboard example that we have provided in here. That's how it's going to look on the governance level, and we'll have a score towards the end of the year. But the standard metrics that we're going to be tracking on a regular basis, and we'll do periodical reporting on those. But this is an example of how the dashboard is going to look like. We are going to keep refining this dashboard as we go, as we learn and develop and understand the data. But this is an example of how it may look like coming forward. So what is our next step? So as I said, next step would be developing those baseline and benchmark for the snowball metrics that we just explained in all three aims areas. We'll have periodical board updates on the goals and the measures that we have. And of course, as Anna was saying, some public and the board may be interested about knowing a little bit more into the depth of the data. We'll have some periodical office hours as we move on into the next fiscal year. With that said, I want to give it back to Anna.
Well, thank you. So I just wanted to say that we actually, as you see, I brought a lot of reinforcements. We're happy to have a conversation with you. But I do want to say that, again, hopefully what this kind of walked you through is that we are introducing some new and novel metrics, but you're also going to see some standard metrics. I do want to point out that the third next available and some of those things, one of the things I Dylan sort of just says that it makes it seem really easy, but we really hadn't done the analysis behind some of the goals that we set. And so these, we come to you with these goals, and these are, we have a lot of confidence in the analysis. They're actually all stretch goals. Some of the novel metrics and some of those things, like, for instance, you're going to hear a little bit more about the governance development a little bit later in one of our next presentations this evening. But you can see that it's not filled out throughout the year, because actually that's going to be developed in partnership with the board. And so we know some things are going to happen, but we expect that the board is going to want to fill that out in a little more, with a little more sophisticated and board level perspective of what you want. We just sort of set out some, I think, general aims that we got from listening to your retreats. But the other thing I just wanted to point out, I want to go back to just really quickly to the dashboard, because we talked, Crystal talked about it, and I think it's important, and we'll be talking about this over and over again, because again, we know that this will be new, maybe not for all the board members, but certainly for maybe members of the public who've been following along with this system. This is not the way we've done things in the past. And so things like the novel metrics, when you do reporting only, for those of us who remember things like the DISRIP or QIP, and I know some people, the hair standing on the back of their neck is standing up right now, but those things are things like, CMS or HRSA or NCQA or others. They will push out a measure and say, health system, you must report on this measure for 5 years, and you will get dollars, incentive dollars for reporting on this measure. If you report on the measure, and you can, basically, if you just submit your report, you get the full points. I just want to say, which won't feel necessarily like a stretch goal, but it is. That is actually how measurement science is done. And so we will be assigning the points for reporting only if we do the reporting. That said, it is a novel metric, and we have designed this metric up against our theories or maybe best known evidence. But one of the things I want to point out that Farhad said is, like, not every community is going to be measuring their snowfall powder index. So you won't have a national standard necessarily to go by. And so again, we really feel like we have to have the discipline and the rigor to make sure that the measurements that we've designed are actually measuring what matters to the community and really the problem that we're trying to solve. So this will take some discipline, and this will be different. There are, though, in there some very standard metrics like number of clinic appointments, third next available. As you saw, Louis walked through the balancing measure, so it's not like we're not going to be looking at finance. We are, and all the other, satisfaction surveys and experience surveys. But what we're bringing to the board is what's directly attached to True North. And then you'll still be getting your financial reports. All of that will still be there, but we really want to highlight those things that the community and our employees and those 6,500 touch points said mattered to them. So those will be coming on a regular basis, whether they're pretty or not. So I just wanted to sort of make sure I kind of highlighted that. And so with that, I think that concludes our formal remarks. We anticipate there will be some questions, and then we'll hand back to you, Chair. And if there's any hard questions, it's front row right here.
Thank you very much. I'll open it to the board for any comments or questions.
I have a question, but I think I'm getting ahead of myself. And as we're talking about these measures, in another part of tonight's evening, this evening's agenda, we're going to be talking about incentive compensation, and then measures that are going to fall out of incentive compensation. Is there an alignment between the two?
We think so. We think there is. I mean, there will be some things like finance is not up here, but finance will definitely be, I think it's a very community standard to have a finance, metric, to have, there are some metrics, around performance that may not be up here that we will be adding, but those are, you will find those in our balancing measures. So that, you'll still have access to those, and those will still come in front of you, particularly at the Executive Comp Committee. But within the entire measurement strategy, it will all be there. Yeah.
And where we mostly see the novel ones are in our newest three of the access, and not access, but healthcare within reach, transformation, and audience, non-audience.
So I think if you're asking, Mary, the True North measures will not displace things like finance and patient satisfaction as it relates to executive and leadership comp. Those are definitely, and those are very, I would say, very community standard. That's very common for executives to have a set of performance measures, but also it just starts with finance and patient,
I'm
experience.
thinking of a portion that has to do with key strategic indicators.
Hello?
Hello?
But we'll see that when we get to it. Thank you.
I've got a question if I could. Crystal, I'm delighted to hear that we're going to try this reduction in lab costs. My recollection is that if we lower the cost of labs to any one group, we have to lower it to everybody. Am I correct in that?
We don't get to pick and choose who we lower prices for.
Yeah.
So it's all for one, one for all kind of an approach. So
yeah,
there's no particular classification. So if CBC was $100 and we're dropping it to $75, that's for all payers.
Okay. And so I'm thinking of the balancing. Obviously, the balancing is we presumably will retain more patients that leave us to go to Renown or elsewhere for the services, thinking that because our lab costs are high, everything else must be high. By lowering lab costs, we can change that thinking, perhaps. Prices have come down, so maybe I'll stick here with Tahoe Forest.
That's why the metric is utilization.
Okay. So that is the thinking?
That's the novel metric, is we will be reporting on utilization.
Yeah.
To see if our utilization changes. But with that, if we support our community with seeking care in their financial needs through our financial assistance program, we may also see greater utilization, but we may see greater utilization in our financial assistance as well. Again, we'll be reporting on that. I have nothing to measure that against at this time other than to see. Let's see what happens.
Let's see what happens, sure. Is your calculation that we will lose money on each lab test as a result of this reduction in price? Or?
Yes, so if you recall in the budget, we were anticipating a $2.3 million reduction in our net revenue.
Yep.
And I'm not talking about bottom line. And clearly, our delivery structure will have to ebb and flow based upon utilization. So if the utilization does go up quite a bit more than we expected, we'll have to add infrastructure to handle that.
Yeah.
But we are anticipating a $2.3 million reduction in our net revenue if utilization does not change.
Yeah, okay. All right. Well, it's not novel thinking. The grocery stores do it. They bring people in with lower prices on coffee or bread or something.
Maybe they'll sell more. We're not a grocery store, but we're hoping it improves access for our community to be able to seek services local.
Okay, great. Thank you.
No, you're just waiting.
More of a comment, maybe a discussion, maybe the board, Emily can help me. Great analogy on the grocery store. So I'm at Safeway, and someone taps me on the shoulder and says, "Hey, a lot of stuff's happening at the hospital now. I was on this survey, and so what's going on there?" And so I guess when I think of that moment in this, because we're all here. I'm looking at the crowd here. I'm looking at all the people who know this in and out. But I'm thinking about people I've met already, who I've talked to. Oh, there was a 5,000 voice. Oh, can you show me? And by the way, 3 days later, I gave my pamphlet away, so I need another one. But it is that moment of sharing with our community this, understanding that, yeah, we did. This is you, the community. We listen to you. This is, we know you want to see your doctor. We know that there are significant barriers. We know that this is going to not only, require new ways to measure things. We're going to have to do things differently, and we're going to keep you involved. Is there anything does that sound right? Anything else you would add? If you're in front of me, in front of the grocery line, I could tap you and say, Anna, what else can we tell this person? What else can we tell that person?
Well, I mean, I love it. I could ask that too. There's only 2 grocery stores here, so we're all getting asked this. And honestly, I don't know how everyone knows, because we only have, we have less than 20 people watching YouTube, so I don't know how everybody knows who we are, but they do. Every single person, and Lisa, get ready, when you're at grocery shopping, you have to have all the talking points ready to go. But I would say this, it's true. First of all, I would start, and I do start, by thanking people for taking the survey and giving us input. I mean, it's really incredible, like, how much time and care people put into giving us feedback and suggestions. And these goals, health within reach, guided by the community, and really transforming, and that transformation is really about making sure when we do things, we're doing it differently, like with the community, and we're preparing our staff to actually think that way and work that way. I mean, they've got the care part down, I mean, really and truly. But I think that what we know is that the community is rooting for us. They have a lot of ideas. And so really the measurement strategy here, a couple of things they said is like, we want end. So we do have some volume metrics here. We do have that, tracking of the third next available here. But we also heard we want things to be more affordable. We know that was really the big examples I got in the grocery line were labs and imaging. We had a model to build off the labs. Imaging is a much more ambitious and complex endeavor that after we get a couple of years of the labs down, that we really understand if we do have an understanding of the demand. And I think, just to reassure you, we're not giving you the totality of everything that's going on. Farhad and Dylan are doing things like, as we talked about, those, 800 increase of 800 visits a month. We're also modeling out what will that result in, how many ancillary kinds of service, labs and imaging. So, again, which is, we need a lot more information, but I would just say to the community, we're creating more access for you. And it's not, we're giving you we're picking 2 really tangible things that you can speak to, that the community can understand. The 800 more visits a month, and the, third next available, so there's just the general access. But remember that we're also going to be introducing telehealth. A mobile clinic will be rolling by, this time next year. Louis says March. Springtime. Lauren's nodding too, so that's double confidence I have. But it's not what we're doing. What the community asks us to do is create more choices for us. Like, I don't want to just have one option. And so we're giving you 2, what we feel like are 2, these are proxies for a whole plethora of work that's going on. So I think what you can say in the grocery line is we're working hard at creating more access for you. That will include things like more appointments. That will include, things like maybe some telehealth. But it will also, you're probably going to see a mobile van rolling around here, within a year. And we're also doing all kinds of improvements inside of the clinics to really streamline the workflow, to figure out how we can, free up, our really unshackle our medical staff from doing administrative tasks, and really free them back up using things like technology and AI to get them back to the bedside or the exam room where they're looking straight at the patient. I mean, you know because you're a provider, or some of those of us who were in healthcare, it was very different, and patients aren't just longing for more, they're longing for better. And so I think you can say that at when you're at the grocery store. The other thing you can say is, I'm really glad you asked that question. And we have some on-ramps for you to get involved, like the Patient and Family Advisory Committee. We're also going to, we're working on a 5,000 Voices 2.0, and I just talked to our Chief Strategy Officer last week, and these are the 3 things she said you can do. So those things you will be able to say. And then finally you can say, things like, we're also working at the governance level on how to better how to ensure we're doing the work of the community, but also how can we make sure we are supporting staff and getting the tools, because it's not just about more stuff. It's about it's really about really being responsive to what the community asks us for. And this is what the measurement strategy around the True North, those, which I would say, you'll say later, to tie back to your compositioning, that's a piece of the deliverable for the executives and the executive team, but it's not the whole thing. But it's an important new piece that we haven't sort of made that promise. Those are promises that we're making to the community. It's also on page 7 of the write-up, of the written one. It kind of gives you just the snapshot of it, where you can kind of use the bigger goal, or you can use some specific deliverables. Depends on who you're talking to. Some people, giving them the general goal isn't going to be good enough. You're going to have to say, we're going to increase it by 800 appointments a month. There's like 4 people in this community. I know them, and I think they shop both at Rayleigh's and at Safeway.
Could I ask you a question about the marketing strategy for rolling out this reduction in lab costs? Are we just going to silently do it and hope the community recognizes, or are we going to take credit for listening to all these 5,000 voices or 3,000 of them who complained about lab costs, and say, in response to that, in an announcement, we have made this adjustment?
Yeah, we're not going to do anything silently as long as I work here. We actually will come back to you next month with sort of our messaging around the affordable labs. We met about that today. We'll be working in partnership with Crystal and her team to figure out what our key messages are around that and how we're going to explain it to the community. It's incredibly complicated, and we want people to walk away understanding what the benefit is to them. And so we have to do it repeatedly. We have to do it carefully. We have to do it clearly. And so next month we will be back with what I would call a suite of tools. And I would say that about your question as well. We're working right now on sort of a one-pager around our strategy, what our talking points are, what our website landing page, all the actual tools that you need to be able to answer those questions, and we will update those on a regular basis, as needed and as we see an opportunity to spread a message. But I feel like it's really important that we be very upfront with our community, and that our community clearly understands exactly what we're doing and why and what the benefit is to them.
We heard you.
Yes.
We heard you and respond. That kind of answers what you questioned.
And we are a public hospital district, so we have an obligation to our community to be as affordable as we can and to be as transparent as we can.
Yeah.
And so that is, I think, the true north that guides us.
Yeah. Okay.
I'm just thinking about your one pager, Kim. Maybe we could put it in a rack. It would just help a lot, wouldn't it?
We're live, we just hand them a sheet.
More than go to the grocery store. All right.
Mary's going through some trauma. Let's work it out, Mary.
I think that's a great idea.
I wasn't joking. I was joking a little bit, but it actually does come up on a regular basis.
Yes, it does.
Which is, I won't ask which leaders, Instacart or whatever, do the curbside, but I think many of them do, and I'm not sure how much that weighs in on it.
Well, I'm going to date myself without disclosing how long I've been in this business, but there was a time prior to websites and prior to social media where stuffing a flyer in a grocery sack was a way to get information out. Yeah. So you laugh, but that was a thing.
Yeah. Okay. I love it. Yeah, that's great. Okay.
And just that's interesting to me about the novel strategies that we're going to be using, and yet having the balancing metrics to go with it, because that was my biggest fear, is that we're engaging on so many new things that we can't forget where we want to be with quality, where we want to be with our surveys, with our employees. So I'm glad to see that being monitored as well.
Yeah, and I think one important maybe thing that we didn't point out, but I think this will, this really relies then and makes important the work of the different assignments of the board on the committee structures. Because that's where you're gonna see some of those balancing metrics happen. But at the full board and at the public level, we're gonna be bringing you a more synthesized version, but the committees may then, and that's the other sort of piece I wanna say is that you don't just have to rely on solely on the senior leadership or executive team to kind of decide when something's derailing. These balancing metrics and those sort of standardized operational metrics, finance, they're still going to be at that committee structure, and those board members that are assigned to those committees will have the authority and duty to decide if this is kind of moving outside of the threshold of the board, and can decide, let's advance this up to the full board to talk about, because this feels like an outlier now, or this trend is no longer comfortable for us to work on at the committee level. So we're bringing you at the top level, but there's actually work for the board members in their assignments. They will be looking at those balancing measures as well as some process metrics along the way at the committee structure level.
Thank you.
And I think, Mary, I'm going to build on perhaps your comments, and I'm seeking a little bit of understanding. One, I appreciate the primer on measurement science. I believe I understand the difference between a standard and a novel metric. When I look at health within reach, the goals, key to any measurement science would be having things you could measure, I would think, right? So clearly, 4,000 visits per month, very measurable. 30 days, they're next available, very measurable. Even within the financial assistance, and I appreciate and recognize that a novel goal or novel metric is not going to have a baseline. It may not be able to say we're going to improve or change by X amount. But even within the financial assistance, I can form a hypothesis against those. They're measurable, right? Lab test utilization. Our hypothesis is it's going to go up if we reduce prices, I'm just assuming, right? We don't know, so we're going to watch, So that's why we can't measure against a baseline, but we can measure it. We can measure utilization.
Correct.
And the same thing for financial assistance, right? If we improve process or improve it, we would expect to see it go up or down. We can form a hypothesis, but we can absolutely measure total financial assistance. When we go in,
I will say about those two, both of those, we know what the lab study utilization was. We brought that, those data to the board, and it's like, this was involving about 120,000 studies or something a year. I'm pulling this out.
I think that's right.
It's about that. But we also know, and so that in that case, we know what we did, but we don't know what the impact of reducing the price will be, so we'll just tell you what happened. That'll be an observational study. Yep. But in the financial assistance, there's two things happening. One is we're going to do the observation, but we also, one of the things that changed from the last set of data that you had to this next set of data that you'll get is that the state changed the rules. So, the state has actually changed the inclusion criteria to expand it, actually. So, that data will be, the historical data, even though we'll have historical numbers, it won't have as much meaning. So again, really important that we measure it over a baseline period and decide, okay, now this is a validated, stable measurement. If we were to measure now, we can tell you what it was last year, we can tell you what it is this year, but we actually can't tell you why. And we also can't, it's really not the same, it's like comparing an apple and an orange. Because the state changed the criteria for using or being eligible to use financial assistance from
and I appreciate it and understand it. But something like lab test utilization, we know what utilization was last year, right? Why can't we set a goal against what it could be? We don't know how we're going to get there. We don't know if price reduction will generate the goal, will achieve the goal.
That's exactly right. So by reducing our price, we have no idea to tell you, okay, I'm going to drop our lab price by 25%, and that's going to raise our utilization by 5%. I have no idea.
I think we're mixing cause and effect with establishing a goal and striving to reach it. Cost reduction might be one way to drive lab the goal is to increase lab utilization.
So did we
is
or
it
did we not do it? To me, this is a yes or a no. That's part of the report.
Well, did we do it, and by how much?
I don't know if I would just maybe put one more caveat in there. I don't know that we actually determined the goal is to increase lab utilization. The goal was to reduce barriers to utilization. So you would predict we may see an increase in utilization, but the goal was to reduce the costs. It was an affordability goal.
Mm-hmm.
It wasn't necessarily a volume goal. So I do want to say we never actually built in, and when we modeled and we brought you what we predict the cost will be, it wasn't designed up against an increased utilization. That said, and that's why we really didn't want to necessarily set a goal, because we don't know what the impact of reducing the cost will be.
Mm-hmm.
We hope that it will mean that the doctors will be more comfortable to refer in. We hope that it will keep people from, leaving the system. So it won't just be volume driven. We'll be looking at market data to see if more people went down the hill. There's a lot, if we reduce leakage, we also might see that we might see an influx because of the telehealth. So we could put a goal there, but I think this would be, I just want to say that and there are some that have had this urge, but I would resist that because it's not science-based to do that. It's just kind of aspirational, which is great, but what we want to do is have the discipline to understand what is the impact of reducing the cost, which is really about, we believe the cost, and we've heard this through the 6,500 voices, that cost has created a barrier in accessing care, and care that's highly coupled with primary care. Labs, are kind of an entryway into everything. So we think lowering the cost of labs could even increase utilization in primary care. So I think there's a lot we still don't know yet. So that's why we want to take the time to observe it. Doesn't mean we aren't going to try to do well, but we actually didn't set out to increase lab utilization. We actually set out to reduce cost. We have theories on what that's going to do to utilization, but
That's what I'm trying to get at. Then is that the goal, to reduce cost?
We did that.
Okay.
So now we're trying to measure the impact of doing that. Did that have an impact?
Right.
this is the affordability arm, which the board sort of asked us to work on affordability. Now, that said, I think you're there. You're 2 years ahead, but we're just asking that we take the time to understand what does it look like. The other thing is, before we set a goal, it may not bear out the way we thought. It may be much more cost to the system, and the board may decide we might not be able to support this policy in the long run. I'm not saying the board will, but I'm saying this is we made a policy decision to literally, this is a investment in the community. It's a straight up cost to the system, and we think we know what's going to happen. We have some ideas, we have predictions, but we have to run this test and really make the observation. So again, we could set a goal, but then you have people chasing the goal rather than understanding what the impact of the intervention was. And so we would just like to take that time. But you're right. If we wanted to, we could set a goal. But as a person who has some adherence to measurement science, that would be a little bit arbitrary and a little premature. But we could.
Mm-hmm.
And I would recommend against it.
Well, my fondest hope would be that those people who I know, who've told me, I go down to Carson, Tahoe because it's cheaper. Now, I don't know what they mean. I don't know what's cheaper. We benchmark ourselves when we set the budget every year, and our top 25 most common medical procedures compare favorably with the hospitals and in some cases beat them. But obviously, what you're dealing with is perception sometimes. If somebody says, gee, they've gone down 25%, and I recognize it and I appreciate it, So I'm going to come back to Tahoe Forest for all my medical services. That, to me, would be the greatest benefit from doing this program.
I mean, that is, again, I think that's what, okay, so we've talked a lot about the 6,500 the 6,500 touch points of 5,000 voices. I will remind you that one of the big inputs of our data was the market analysis, and we know that we're losing people out of this market. And one of our theories that we believe is leading to that is the cost of labs and imaging, which is why this was truly an affordability. This is an affordability pilot. I think you're right, Michael. I think it will impact utilization, but we don't yet know how. But we also don't know if we can withstand the price reduction. So to push people to have a goal when we don't understand what the impact of that might be, a utilization goal when we don't yet know the impact and we don't know if it will result in reduction in market. I hate the word. Which was the word you decided to use of leakage?
Out-migration.
Out-migration.
Yeah.
Sorry.
Yeah.
Well, because we don't like to use the word in healthcare. But, so I guess.
To avoid a kind of protracted conversation, I appreciate all that. I think going back to Mary's point, we're going to be asked later in the evening to put real percentages for incentive comp against goals. And so to reach, for example, financial assistance goal is you have to report. But there's no, okay, and that could be 3 sentences that says, we looked at lab utilization. Like, that's a report. I'm being a little bit of a smart ass here, but that's a report. So how do we as a board assign real percentages against real dollars for incentive comp for a novel metric? Should they be included in that? Or should they sit on the sidelines for the year, or 2 years, or 3, whatever it takes for them to become a standard metric to where we can put goals against it? So I think that might have been part of your conversation. So we're thinking, I think, through the rest of the meeting. And then same would go out without going into details, for community guided, leveraging PFAC. Great thing to do, but it's not a goal, but we're going to be asked to put a percentage of real dollars against those goals, which are both just reporting goals, which is hard to assign value to. Percentage incentive comp, dollar value to, not value to the organization. These are incredibly important things to be doing, for sure. I think where I'm challenged is how do we translate that into sort of rewarding performance against goals if the goal is to report.
Well, and I would just say it's a good question, and one of the answers to that, I'll just again draw like on a CMS, which is big dollars that they award out, and it's basically based on deliverables. When you have did you deliver, which is sort of when you saw some of these, you saw literally timelines and stuff, and so if you don't feel you've been informed or you were derailing or we failed to deliver, then the board has the option to do that. Not all, I won't speak for, I will allow the compensation specialist to talk about this, but some things are, some things do end up at executive level. They're subjective. The board, but I believe that there are hard numbers in much of the incentive portfolio. At least that is what I'm imagining as I think through that as it relates to the executive staff. There's finance, there's safety, there is, but you're right around the community guide and the transformation. That is one of the reasons why we have these timelines, out, because even as the executives, as I think about what they're doing, I have to sort of figure out, are you on track? But the other side of that, in all fairness, those are entirely new measures. They're entirely new kind of portfolios and scopes of work. I'm reserving the right, as it relates to the executives, to decide this is what we think the milestones are going to be and how they're going to be. But at the end of the day, I actually won't be able to use just a scorecard. I have to use my, I have to assess whether, like Brian didn't hit that milestone, but I know we had 65 meetings, I know this and that, and there are things, and so I do have some flexibility within that to determine whether Brian's working up against that goal or not. No, I don't think at an executive level, everything's outcome driven. At least that's not how I envision assessing the executives. There is some within here, you're right, there's some gray zone embedded in here, and for me, that's on purpose. Because I do think that there is some, that, and I think that that's standard. But again, I will defer to I will allow that to kind of come up and you can talk, the board can opine through that with the compensation expert. Yeah.
I think we just jumped ahead of ourselves into another topic that we're going to be ending this
We're not
discussion
solving
with.
that here, but this will factor into that conversation for sure. So I was just trying to get a little bit deeper understanding around, for example, transformation. Every single one is novel, which makes sense. We've never taken on transformation as a goal or as a.
And this is our job, right? Our job is to approve this or approve this with modifications. So getting clarity on the modifications, what we can approve, whether we ask for specifics, that entire discussion on making sure, do we guess on increased utilization, numbers, novel people using labs? I think, that this helps us decide as a board, is there modifications to this that we want to be done? So, thank you.
From the board, any other?
Yeah, Michael, I would just like to commend everybody because I think that from concept to consensus to where we are tonight with actual action plans and what have you, has probably set speed records for this organization.
Yeah.
So I just think everybody should pat themselves on the back, and it's going to be an exciting journey.
It is. Yep.
All right. Any other comments, questions from board? To the audience, any comments or questions?
Hello, Megan Shirley, Population Health Medical Director and PA in Primary Care. Thanks for explaining this big packet in a really understandable fashion, and I love the powder analogies. I had just one comment and just a curiosity, but I wanted to just express my appreciation for some of the terminology used in the presentation to include medical staff and not just physicians. It's great to see that kind of broad thinking to include all of the different medical staff categories, which would include PAs and NPs and many others. So I think that's appreciated by myself and probably many others. So thank you for that. And then secondly was just kind of a conceptual question. I don't know who wants to maybe answer it or talk to it, but it kind of goes to this slide, which is really interesting, and thinking about the future state and like how this would be used moving forward. And I know it's brand new, but.
Well, I could listen to it tomorrow, but.
I thought she was going to answer. Great. So with the kind of, I guess, 8 buckets or categories falling under each of the 3 aims, like that's where they are now. But I'm curious if the thought is in the future, those could potentially change if there's a shift in the organization or a shift in what the community is asking for, because some of them may not need to be continued to be looked at. Or I don't know if you guys have thought through that, but I know we recently did an action plan for community health, and that was one of the things we thought through is, some things may need attention now, but they may not in the future. And so is there room for this to be modified, or is this really the plan for the, foreseeable future? And if there was any thought, I would just be curious. Thanks.
I'll offer my 2 cents on that and then allow anyone to correct anything stupid that I say. We're approving these for this year. There might be something like a global pandemic next year, and these might have to change drastically based on the market.
The county health officer doesn't.
Brian says no. Brian says no. And the community's going to change. The industry's going to change. We as organizations are going to change. We're going to achieve some of these goals, and they'll become more the way we do business, and we'll need to set new goals. So I see these as it's dynamic. I don't imagine like 100% of these would disappear and they'd be completely changed next year, but because a lot of the work that we're doing will span years. So I do see that there'll be some consistency, but absolutely we'll have to modify to reflect the priorities and the needs of the organization. Would be my answer. Agree.
The only constant is change.
I would say absolutely yes. And I would say even if the big categories didn't change, like I think the discussion you just heard with the chair, you might see the lab thing move from a reporting only to a utilization aim with a cost aim or something. You will see you should expect to see these novel metrics either get further defined or become standardized, sophisticated measures once we have a better understanding of what we're trying to achieve. So I think, again, we may decide that once we kind of hit the affordability threshold that we're able to do, then we really start to figure out how can we scale that and increase utilization. So even if we didn't change the categories, I would expect the measures to become more sophisticated over time, but I would also absolutely expect the categories to change because hopefully we'll be sunsetting some things, or maybe not sunsetting, it's not on here, but finance will be tracked. It just might not be pulled up, to the board dashboard level, but, board's still getting their finance report every month and all of that. So there's lots and lots of measures underneath these measures, but they will switch around sometimes depending on what the priority is, or depending on an area that's really an area where we really need to improve. Yeah.
Great question. Thank you. Any others? Comments, questions? All right. Thank you. Directionally, again, Mary, I feel like I'm always just building on your brilliant comments, but directionally, I think this is fantastic. So please don't take my curiosities and clarifications as a challenge to the value of this. It's more just seeking understanding. With that, this is an item for action. We would be looking for a motion to approve the 2030 measurement strategy.
I'll make a motion to approve the True North 2030 measurement strategy.
I'll second that.
All right, motion and a second. All in favor?
Aye.
Opposed? All right, approved unanimously. Thank you very much. Item 15.2, True North Governance Work Plan. I might tee this up and then Kim pass it to you because I'll save some time on the back end from a committee report. But Governance Committee met. We did work on a recommendation for the Governance Work Plan. There was a debate as to whether it should be just in the consent calendar for standard approval. Because of the nature of the work plan itself, that we felt at least having an opportunity for the board and community to discuss. But we don't anticipate it to be wildly controversial. So it almost went into consent, but we wanted to bring it forward to the full board just because the impact of the work plan will affect how we as a board operate. So Kim, I'll pass to you.
Thank you. We have Larry Gage with us on Zoom. I want to thank him for hanging on with us. He's in Washington, D.C., so it's a little late for him. So thank you, Larry. Just a couple of, to build a little bit on what Michael said, governance is one of several work streams that we're standing up in support of the True North office and the aims that we've identified. This plan that Larry will be presenting came out of the retreat work that we did. It's his recommendation on how to meet sort of the three different focuses that came out of that work. Those focuses are sort of better defining the board's fiduciary and policy governance responsibilities and how those support and differ from what the CEO and other executive responsibilities are. It allows us to sort of explore and broaden access to the community and community access to us in terms of advisory committees, task force, other governance structures. How can we look differently about how that structure is in place that allows us for more voices in the decisions that we make? And then a continued investment in board education, in committee effectiveness, in the planning process, just making sure that the logistics and the day-to-day is in place. So we want to be really clear that this work really builds on the existing strengths of the board. This is an incredibly strong board. I've worked for a lot of boards in the past, and I thank you for your support every time we come before you. You are complimentary and supportive, and that goes a long way in terms of how the organization feels. And so I thank you for that. And our objective only is to continue to grow on those strengths and figure out how that continues to be something that we do. So with those comments, I'm going to turn it over to Larry, who is much more schooled in this than I. Mr. Gage.
All right, thank you. Very nice to be with you all. Do you have any slides that you're going to show?
The slides are up, so I'll just move to the first one that is yours. All right, the timeline slide is up. Larry, can you see that?
I cannot, but I will proceed anyway. I'll just tell you to move ahead and expect that. Because I'm going to be brief again, as the chair indicated. This was discussed in some detail last week at the governance committee, and I really just want to describe the governance work stream and action plan really in the context of how it will support and contribute to the success of the broader True North strategic plan in all its aspects. And as Kim has outlined, and as I think this slide is showing you, this action plan is going to be divided over what we hope will be a pretty quick 3 to 4 months, largely into 3 parts. First part is the development of the action plan itself and the governance work stream, a process that today should be largely completed. Second is really an information gathering phase, which again has been started. Even before now. And the third will be the analysis and the recommendations, including a final report and implementation plan. Next slide. Now, following the May 28th board approval of the True North strategic plan and the governance committee's approval last week of this plan, we expect to the board to consider this today and to reach, as you just did on the actual strategic plan, approval moving forward of the work for this year for the next several months. Next slide. Subject to your approval today, we will begin our formal review of the documents we've requested, many of which have already been provided, and in fact, some of which have already been reviewed. Over the next very few weeks, between now, really the end of June and mid-July, we will be finalizing our review of the various documents and other background materials we've collected. And during this stage, we are also going to be conducting an inventory of the formal and informal Tahoe Forest Health District governance and related entities, structures, subsidiaries, advisory boards, joint ventures, partnerships, and the like. And finally, we will also, during this phase, update our ongoing literature search and draw on our current national and statewide base of governance studies to identify best practices for the board moving forward. Next slide. From mid-July through mid-August, we will be conducting follow-up interviews, both virtual and in person to the extent we can. We will also convene group meetings and brainstorming sessions to consider potential options for acting on the governance recommendations in this plan. Next slide. These sessions are going to include consideration of options for broadening the scope of system governance in ways that are consistent with the California Hospital District Enabling Statute and other legal requirements. And as this slide indicates, I hope, because I'm not looking at it, we're going to be considering such steps as creating a matrix to identify gaps in skills and expertise. We'll consider convening an ad hoc working group of some kind in the short term to advise the board and leadership on potential reforms and then developing for board consideration a plan to expand system governance, again, sensitive to the requirements of your enabling statute and your own current bylaws to include community leadership and regional and national subject matter expertise, while also improving the ability of medical staff leadership to participate in system governance. And this overlaps with other work streams in the broader strategic plan, and we'll be coordinating carefully with those work streams. Next slide. Same time, we're going to seek to clarify the governing board's fiduciary and policy development governance responsibilities, the delegation of planning and operational responsibilities to the CEO for execution, and again, formally compile examples of best practices to serve as a basis for our final report. Next slide. And finally, as we begin preparing our final report, we will consider a number of other deliverables that were identified both in the March retreat and in the True North strategic plan. And these include the following areas that are identified in this slide. I'm not going to read them to you, but I call attention to the fact that the second bullet, for example, we will be considering improvements to education, support, planning, the use of committees, the cadence of committee meetings, among other issues. Having said all of that and having set out these bullets, I will have to make clear that we are not going to be proposing change for the sake of change. As Anna, I think, stated a short time ago, we're going to be looking very carefully at improvements to a current structure that is very, very sound. And so far, we've enjoyed working with the current board, and we think you have a good one. We're going to look for it's the old physician's ethical principle: first, do no harm. We're not going to be suggesting things that will set you back, but things that will support the entire strategic planning process. In fact, in keeping with the powder and the snow analogies, I want to offer, I think, one of the very best pieces of advice I ever had, actually from a hospital system president who happened to also be a ski instructor at Vail in Colorado. And after I had lost a ski pole and a pair of prescription sunglasses, he said, you know, the best advice I'll ever give you is don't fiddle with your equipment on the lift. And so I want to make sure that we are not going to be proposing changes that will disrupt, but rather that will lead you to improvements that will support the entire strategic plan over the next several years. And the last slide, of course, we're going to be hoping, I mean, this is ambitious because of it's summer, people go on holidays, but we're hoping to prepare a report in 2 stages with an initial report for everyone's comment by early to mid-September and a final report scheduled around your own activities. And the end of September is a very busy time for the board, I know, but to have a final report in your hands by the end of September or at latest early October. And that's my presentation. I'd be happy to answer any questions you have.
Before we do that, if I can just make one more announcement that has happened since we posted these slides. We have appointed Sarah Jackson as the project manager for this work, so we're really glad to have her on board. And we have Kelly Downs in the room tonight, who is the change manager for Tahoe Forest, and she will be supporting Sarah in that work. So I thank both of them from the bottom of their heart for the day-to-day support making this work go forward. So you won't have to count on just me and Larry.
Thank you very much. And thank you. Yeah. As you didn't have enough to do already, yes. Yeah. Before I open up to questions, comments from the board, I just want to clarify, because we went through this a little bit in the governance committee. This is essentially a plan to build a plan, right? So even though there's conversation in here about things like, recommendation for, subject matter experts, and we're not proposing any of that happens. The output of this work plan would be a plan and recommendation that we would then further adopt. So just clarity on that. Yeah. With that, any comments, questions about the work plan itself?
You know, the definition of a goal comes to mind here, or at least my definition of a goal that I've heard before, is a goal is a dream that is measurable, attainable, and has a timeline. And to me, this has all those elements, so I think it's great.
Fantastic. I am gonna, unless. To our audience, any comments, questions on the governance work plan? Hearing none, seeing none. This is an item for action, so we'll be looking for a motion to approve the True North governance work plan.
I would move approval.
I'll second.
Motion and a second. All in favor?
Aye.
Opposed? All right. Approved unanimously. Larry, we're not going to even wonder if you have pajamas bottoms on, but thank you for joining us so late in your evening and for the work that you've done so far.
Great. Look forward to it.
All right.
Good night. Good night, Larry.
Thanks, Larry.
All right. Final item for board action this evening, fiscal year 2027, President and Chief Executive Officer incentive compensation. I have John's name here, but I believe, Alice, you're going to at least get off the conversation.
Start the conversation about the incentive comp in that the Executive Compensation Committee met on Monday, and we were introduced to some concepts and structure that could be used for incentive comp for our CEO. And after a long discussion, we agreed on a framework to use. And we've had a discussion with the board previously today about what the structure was. And it would include a point that we would have to reach financially in order to start the incentive comp program. And then we would set thresholds, a threshold that they'd start at, the target threshold, and then a maximum threshold. Then we looked at how to align it with our True North priorities. And we're gonna look at the budget or finance as the number one, quality, and then we have our key strategies, which would be health within reach, community guided, and transformation. And what the board will decide is how to break those down into percentages that would equal the amount that the CEO would receive for just the incentive comp. And so with that, the board has the framework in front of them. We did give some recommendations for how to divide the percentages up, but that is a point of discussion that our board can have and that we would all agree on to go forward in fiscal year 2027. So again, we're setting it up for the fiscal year. So I've already talked to you about the triggers that would start the incentive comp, which would be 80% of the budget's net income achieved. And then the performance metrics include finance. And initially we gave 30% as the percent we would.
These are the weighted metrics.
The weighted metrics, right. And then 80% of the budget's net income is the threshold, the 80%. Our target would be 100% of the budget net income, and then the maximum would be 120%. So if you looked at a line going up, we'd have the threshold, the target, and the maximum. Our next one was the quality metrics, and we gave that 25%. Again, that would be looking at all our quality indexes, including patient satisfaction. And then our key strategies, we were giving health within reach, 15%, community guided 15%, and 15% transformational. We don't have the exact metrics for them, that we will come up with those once we see what happened with the 2026 incentive comp metrics, so we know where we've been, so we know where we're going to go. So with that, I'd like to open it up to the board to discuss the framework that we're proposing.
Thank you, Alice. And I think just for general comment, the publicly available packet, I believe, had an infographic in there that was for example purposes only. So what we're looking at is actually different than what was in that packet. We had a printed revision to that. So,
yeah.
I think it was for example only. It's reflecting all of what else just.
Yeah.
Yes.
No, if you have this.
Can you do that one?
Do you want me to pull the?
Yes.
The recommendations?
Yeah.
Yes. Yeah. This is the committee's recommendation.
Just it'd be helpful for everyone to see what we're looking at. Yeah.
This is the committee's recommendation following Monday's committee.
Okay, great. So now as everyone can see here, as Alice explained, so the plan trigger is 80% of budget and net income achieved, meaning if 80% of that budget is not achieved, then none of this applies, right? It doesn't even trigger the incentive comp. The weighted metrics, as the recommendation from the comp committee, was 30% of the financial metric, 25% a quality metric, and then 45% would be the key strategic metrics broken down equally between health within reach, community guided, and transformation. So the discussion we have in front of us is either to approve this as recommended or make recommended changes to it. So with that, I would open up first to the board for any comments, questions of the process, or questions to Alice, or.
And we have John from
John.
A&M, and he has been our specialist.
I don't want to interrupt the board's proceedings, but one clarifying point, and Michael, you brought this up, about the difficulty in measuring the key strategic objectives in terms of quantifiable. The one thing I would say, having worked with many, many plans over the years, incentive plans, is that those companies that add key strategic objectives really accomplish a lot more for the organization than ones that rely solely on financial metrics. Only because you change the organization in different ways, and you provide incentive to keep doing what you're doing with regard to the strategies. So the difficulty is, this is the area in which I like to say, and I think we had a laugh the other night when we talked about, it's like objectively subjective, okay? And when I say that, I mean, you have the point of the exercise, the point of the goals really is the process. It's the process, milestones, reports, building tools, and so forth. That's the goal of the particular area that you're talking about. There are quantifiable, there are measurable numerical goals that you have, but other elements really are subject to board discretion at the end of the day on whether they achieved it, based on the plan they had outlined, based on the milestones they had outlined, the meetings that are going to be achieved, the educational process, building the tools to have that particular element as the strategy going forward. That is the assessment that the board makes at the end of the year to see whether it's really been reached. So it does have a measure of outcome measurement that is not necessarily numerically related, other than, if you say, 4,000 visits or, one of those elements, obviously that's easily measured, but there are other elements to the process that, as long as you outline it, those are the objectively subjective, to the extent that you outline the elements that are to be, measured.
Mm-hmm. Thank you.
Hope that helps.
Well, thank you for that, John, that clarification.
And so, comments, questions?
I'd love to go first. I think the first thing for people just listening, looking at the board, like obviously there's a trigger, right? I think that was very great, Alice, you said that, right? If we don't get a financially successful,
80%.
There's no incentive. So we actually have, no one, so I think that's great. So I think it's really important that the audience, the community knows that. I'd like to make a proposal, have this area time for discussion, that we change it, that we go from, keep 30%, I would go 15% quality metric, and I would go
30, 10, 10 for health within reach, 10 community guided, and 10 transformation. And I like, if I may have a few minutes, why. I was so grateful last year, being the new guy, still the new guy, that I look at the annual goals, and I had 25, 26 annual goals in front of me to go back. And we went and we did something different, where we went 20% community, service, quality, people, finance. And we actually got a comment from the audience thanking us for doing that. It sticks with me today. And I looked at, what did we do? What did we do last year that quantifiable, objective, from that? And I think of two things: the community, great success community, greater than 5,000 people shaped community. And we did service, third next available. And I was wondering one, we succeeded, one, we did not. And yet, I think of the one that I was so grateful Anna put her flag in the sand, said, we're going to do this. And it just brought up so much to learn, to improve, to help access and care for our community. And through that in people, I look at, there was qualitative, drive organizational change, develop, implement workforce strategy, work with staff to design. Why do I go here? Why do I go back? Because I have to go back to see what we did before we go forward. And with that, I think as a clinician, the healthcare, as we know, it begins with trust. And you've been here, and I trust you with what you've done. I trust you, what you've built, the people that you've brought along for this journey. And so I do trust that when we have these community guided transmission, that's going to happen. I was thinking, when I was asking what people are tapping on the shoulder, they want to see their doctor, right? They do. I mean, we can talk about community guided and transformation. They're probably checking out, and they're like, I just still want to see my doctor. And then they're going to go check with their friend. Hey, Anna Ross said this, tell me about this. And they're going to buy in. Okay, I'm going to come back. Give me a second. Thank you. I got excited. But when I say, so when I say 30%, I'm very serious about that 30% health within reach, because it is quantifiable, and I think we have to put something where it is quantifiable, and it's what our community wants. As a healthcare provider, I am 100% aware that this can be very construed to any PA, NP, MD, that this means see more people. But this year has proven that that's not what this team does here. And that also proves that that's not our job as the board to, monthly make sure that we're heading in the right direction. So I see it as a challenge, as the next brave challenge. And so that is my thoughts.
Thank you. Can I double check your, I don't know.
I know my math. I don't know. I may put I know. I think maybe 5% discretion, I think, in there. 30.
So keep financial the same at 30.
15, and then 30, 10, 10, which would be 50, 80, 95, and 5% discretion.
5% for me and my friends. Okay. So maybe we go 20% on quality. That would get you to,
Yeah.
okay. Okay.
20% on quality.
That is
mine. That was an open discussion. I decided to throw the ball out there. Alice, what do you say?
Yeah, I think that 20% for quality is the best. I really like to improve the percentage on health within reach, because again, that is what the constituent, our residents are asking for. And it may not necessarily come out in numbers per se, but it'll come out in the process in which we get there, or in some innovative way that we improve access, whether it's a mobile clinic or telemedicine or something like that. And then 10 and 10 for the community guided and the transformation.
Okay.
Mary.
I think it means 25 for.
My turn?
Finance.
I'm reminded of the old saw that says, what is it? What you measure is what you improve. And, so I'm really behind you with the health within reach. I mean, I think that's our most burning issue right now. Normally, I would reduce finance and put it into more of a quality area and what have you, but I do think that we're at a point of financial change, and I think until we can sort of see with greater clarity what's going on, I'd still like to keep that number as high as it is. So I'm happy to go with what Rob is suggesting with the 30-20, 30-10 and 10.
Yeah. Comments, questions?
Yeah, I agree with reducing the quality metric, because our quality is so high. You know, this is an incentive plan. Incentive means it's a stretch goal, and how do you improve when your quality is at the top? It's already there. Obviously, we want to keep it there, but it seems like everybody in this boat is pulling on an oar, and I don't see it as a stretch goal, an incentive issue. So I certainly agree with reducing the quality metric from 25% down to, did you say 20?
20, yeah.
Yeah, and I like the idea of putting more emphasis on the health within reach, and that 30 sounds good, 10 and 10, yeah, I could go along with that.
Not an argument?
No argument.
No argument?
Nope.
Okay.
Just a little. Nope.
10% somewhere
I have
else?
such respect for you.
No, Bill.
The other thing we've talked about is sort of where you place sort of value on the incentives is sort of what you place value on as an organization. And I know we've been wrestling with this conversation for many years now. The financial the weight on the financial goal used to be, I think, up to sort of even 60%. Years and years ago, right? And to the community, that would look like, to a community that's saying already the hospital makes too much money and and we can't afford it, yet you're incenting, leadership to make money, to hit budgets. So I agree, Mary. Like normally I would even challenge that 30% of the financial metric. To me, that's as much just a part of the job as it is an incentive. But because of the financial circumstances of the current industry, as well as some other changes going on, I think that it is appropriate to maintain that at a slightly higher level. And then, Rob, just echoing what you were saying, I think what everyone's saying is health within reach. Yes, community guided is important. Yes, transformation is important, but I don't think the community could have been more vocal in, access, affordability, and choice. And so to weight that a little bit higher this year makes absolute sense to me. So, with that, then we would look to, I'll go to audience for a comment, but just so everyone's aligned, we'd be looking at, 30% maintaining that. It's not on the board anymore. Dropping the quality weight from 25% to 20, increasing health within reach from 15 to 30, and then community guided and transformation both would go from 15 to 10. Okay. I will open it up to input from audience on any and all things related to incentive comp. All right.
It's been a long night.
Well, then with that, we would be, I guess I would recommend, we'd be looking for a motion for the proposed changes in the incentive comp plan, as I had noted, and then the motion to approve with those changes.
I move that we approve the framework for the annual incentive comp for our CEO as what? As revised?
As revised.
Does that work, or should we call out the changes?
Why don't we call out the changes for the record?
Okay, so our framework would be as follows. The performance metrics and weight would include 30% for financial metrics, threshold 80% of the budgeted net income, the target would be 100% budgeted net income, and the max would be 120% of the max, the budgeted net income. Then we have 20 for the quality metrics, 30 for the health within reach, 10 for community guided, and 10 for transformation.
And 80% for the plan.
The plan trigger 80%, yep.
The plan trigger of 80%. Yes, I thought I read that.
Yeah.
Okay.
Yeah, all right. We have a motion, we look for a second.
I'll second the motion.
All right, motion and a second, all in favor?
Aye.
Opposed? All right. 2027 President and CEO Incentive Comp Plan approved unanimously with the noted changes. Thank you, everybody. There were no consent calendar items pulled, so no discussion there. Board committee reports, we did have a governance committee, but I think I already gave the report. Basically, it was the plan, the work plan that's all we covered in the governance committee.
And the same thing with executive.
Same thing for executive comp. Any other committee reports?
Yes, we had community engagement committee. I know. I'll be short. I think it's very hard to come back with the amazing True North plan 4 days later to the community executive committee and go over things. So we kind of pivoted. We pivoted. We celebrated the past year, all the highlights, everything from meeting with TTUSD to obviously Navigation Center, which we did not have part of, but how the community really came together. And so we really discussed it, and it was really, Michael, really a time just to listen. You know, I just had everyone go around the room, just really listen to what this past year, what does it mean to be a community next year. We are. And it did bring about, so that was really our True North debrief. I really, really asking people, what does it mean to go out to the community? And the responses were, I know it's the end of the night, so I'm not going to go into it as much as well. Lauren Lessard gave the presentation, both her first 92 days, I think, close to 100. So I really appreciated it. It was really a great presentation on really just the amazing work we do here as well. And then the magic happened when we talked about the mobile clinic. It was something to be seen, because not only as a board member, it was wonderful to see the presentation, how to reach people, our timeline, but then the ideas just started flowing. Where are we going to keep it? Where are we going to gas it? Where are we going to have the snow load? And it was, and I was watching Lauren just really like, we need to just get this done, get together. It was absolute magic to watch as a board member in there as well. So from there as well, we then reported on our sponsored activities for those in the community. About $100,000 is given every year to those that ask. I think Louis and I, in the beginning of this year, we talked about it, and in fairness, thought, gosh, if we gave up, X amount of money to the sober night at, Truckee High School, why are we not going to North Lake and to Incline? And so it was really, so I asked them to come back next time to show us where did money go, just to kind of see where does health mean for this $100,000 that we, and I thank the committee for meeting every month for looking over it as well. So, and then we awarded the GOAT, which you started. Kim got the GOAT for her 5,000 voices or 6,500, beating the library, because we are competitive here. So it was a pleasure to give, and a pleasure to run the meeting. And then, Michael, I think I may have gotten a little ahead of myself, because, after looking at the governance meeting, I kind of said that as a board member, I'd come back next in 3 months with a new charter. So I'm looking at the timeline of governance. We gotta get to work.
Okay.
We have a few months, but we have to bring back a charter. I have to bring back a charter, and hopefully, yeah, we have lots of help. And so Larry's asleep now, but I'm sure we can wake him up later if we need him. But it was a lovely meeting.
Wonderful. Thank you for that update. Any other committee reports?
Yeah, I got one. I just want to let you know that in an effort to keep Incline Village Hospital connected to the mothership, Anna and Louie and Crystal and Dylan and I continue to make reports to them, monthly reports to them, so they know what's going on over here in Truckee.
All right, thank you very much. Closing remarks. I just have one. I'll keep it brief. Part of what's so exciting about where we are and what we're doing is it's uncharted territory in many ways, right? So being comfortable with being uncomfortable is where some of the fun is. So whether it's conversations around management science, whether it's objective, subjective goals, even incentive comp plans, we're doing a lot of this either for the first time or in a very new way, building out what we've learned in the past. And so while we as a board, as a leadership team, is going to continue to obviously do our best, we're going to get some things wrong, and we're going to have to keep checking back with each other. Did this make sense? Do we understand each other? So I appreciate everyone's participation tonight, but I would encourage, again, on and on. Questions are a great thing, right? It's just because some of it's going to be unfamiliar, some may not make sense. So thank you for the discussion tonight from the board. Thank you for your participation as well. And thanks for all the work and bringing together a wonderful board packet. Appreciate it. And with that, we adjourn.
Thank you.
All right.